Hi everyone, welcome to what I hope is going to be a very lively, interactive and thought-provoking discussion. We have assembled a very complementary and diverse skill set for you on this panel, representing the lived experience, publication, science of all different kinds. I'm going to dive right into doing a brief introduction of the panel, some of whom you've already recognized from earlier in the day, but I'll start with Niall Boyce, founding editor of Lancet Psychiatry, Dixon Chipanda, who's just been on the last session from Friendship Bench in Zimbabwe, Emily Holmes, who needs no introduction, Matthew Hotopf from King's in London, James Downs, who you've just been seeing as well, Kathryn Abel from Manchester University, and Ed Bulmore, who you've been introduced to earlier today. And with that, I'm going to hand over to my co-chair, Kirsty.
Hi, yeah, so I'm Kirsty from Long COVID Support, and I just want to thank the speakers in both sessions for all their talks today, which I think have hugely highlighted the impact of pre-existing inequalities that COVID-19 has had on people's mental health. So whether that be sort of in relation to age, ethnicity, pre-existing mental health conditions, and also sort of the impact of systemic issues, as well as individual sort of risk factors. From a long COVID perspective, another inequality is sort of the focus on acute versus chronic mental health. And that's something that is really important, I think, to move forward into next steps. And also to look at sort of some of the impacts on that can contribute to worsening mental health, such as sort of medical gaslighting that a lot of people have experienced. And on a more positive note, I think we need to look at salutogenesis as well, and actually look at the positive, what can help people's mental health, not just that it is affecting it, but what actually supports and protects people's mental health. Because I would say actually a lot of my mental health challenges have improved over the course of the pandemic in a weird way. So that's something I think that we do need to consider moving forwards. We've got a couple of questions from the audience already. One is around data and sort of demographics based on age, race, ethnicity, and co-occurring mental health conditions. And it says, is there any data on demographics? And I think that was presented, I think, in the earlier talks. But does anybody have any further comments on that? Okay, no comments on that one. I think yeah, it just highlights that the inequalities sort of just get worse with a situation like this. There's also a comment about the key workers, that a lot is put on sort of healthcare, but social care staff, and obviously people in supermarkets and other key worker areas have been sort of neglected in this. Is anybody aware of ongoing sort of research into these areas and the mental health impacts on these groups?
It's Kathryn speaking. So the Understanding Society sample does have key worker data. It's not really very well broken down, but it includes frontline workers, not just health workers. And in the first paper, we found marginal effects for key workers, but they disappeared when we adjusted for things like geography, location, social class, things like that. So we didn't find major effects in the early waves, but we will look at that again in the next paper, which will take the data through March of this year. And we think we're more likely to see those effects in those populations because they've had to endure all of these additional difficulties.
Great, thanks very much, Kathryn. There are a number of, I'm going to throw a few words out in the panel and then come back to some specific questions. So as I've been observing today, there are a number of things that stick out to me. One is momentum. How do we sustain it? Secondly, quality, is it there? Was it good enough in the first place? And how can we make it better? Thirdly, there's integration across disciplines, the whole continuum of mind, body, and brain. And finally, the one that I'm afraid it never goes away and is just important is funding. And we can't have everything we want. And I want you to think about a question that I'm going to go around the panel and ask, which is if you could do one study or one thing, what would it be? But I'll come back to that shortly. Quality is something that's crucial. And I'm going to ask Niall how, I was struck as an ex-physician myself and an investor in the biotech space by how much questionable science got published early in the pandemic and maybe even now. One example I would give is chloroquine for the treatment of COVID-19. How did you guard against this initially? How are you guarding against it in the future? Tell us a bit more about that, Niall.
Thank you. Well, it's an interesting question. I think this question of quality depends on to what purpose are we going to put these data, and while it would be really nice to have complete and fantastically detailed ideas about the interaction between the virus and mental health, we need to ask at each point, what is the priority? What are we going to do with this? So, for instance, a lot of the data so far, which suggests that the issues to do with anxiety and mood disorders, those are useful data to have, especially because we have treatments which can be scaled up to tackle that. Going forward, I would like to see more nuance and more detail. The main issue which we had in the early days of the pandemic was a flood of papers from a mental health perspective, which were essentially cross-sectional surveys, often done online, often using snowballed sampling methods and so on, which we didn't feel would be very useful, because essentially what they were showing was that if you asked a cross-section of people at a particular point who had been recruited in very non-representative ways, if they were a bit stressed, they would answer, yes, they were indeed a bit stressed. So from that landscape, I have to say that the papers which we thought were worth sticking with and publishing and disseminating really stood out. Our criteria basically were that we wanted evidence that these were part of longitudinal studies, that these were not one-off snapshots, but that the researchers had committed to sticking with the data and to seeing how the mental health picture evolved. And this is possibly relevant with the point that Kirsty made about long COVID. This is a pattern of illness where I think we do need a longitudinal picture as well as a cross-sectional one. Indeed, maybe the priority is longitudinal. The data have to be returned to systematically and consistently. They need to be measured with well-validated measurements, not slightly on the back of the envelope COVID distress scale. We need to know exactly what these point changes mean and how they translate in terms of what people are experiencing. The samples, needless to say, need to be representative. And of course, they need to be gathered ethically. I received at least one email saying, because this is an emergency, can you suspend your usual requirements for ethical permission? Well, no, in fact, quite the opposite. And then the other thing which I'm very keen on, which again has come up, is that we were looking for data which would maybe give us some more information about the vulnerable. People in vulnerable jobs, people with pre-existing mental health conditions. That, again, was the priority for us. As I say, these were criteria which we got from very rapidly looking at the landscape of what we were receiving. I'd like to add a bit to the answer, really, which is to do with the way professionals just have discussed health issues and mental health issues in the pandemic, and really a request for nuance. We can select hopefully good data and we can publish it. But of course, what's important is the way this is discussed. I was very concerned, especially in the early days of the pandemic, about some of the wilder predictions, many of which, such as the increase in suicide, have not been borne out by the data. I think one of the lessons which I learned was that it really is incumbent on researchers to learn how to express concern without promoting a sort of apocalyptic panic, because panic is the thing which is very non-productive and actually generating action besides everything else. So that's my answer to your question, but I'm happy to discuss further issues if anyone has any further questions.
Great, well that's very comprehensive and I might add reassuring now. Did anyone else on the panel have any response to that? Kathryn, you talked about volatility in measurements in your presentation, which I thought was really interesting. And there's this whole debate of causality across the entirety of science.
Yes, I think it's quite frustrating sometimes when you use large samples and then you see lots of, particularly in the biological data sets, of these much smaller samples. And the reason given for that is that it's very, very difficult. Having done lots of biological studies myself, it's very difficult to collect epidemiologically biological samples, particularly from people, for example, in distress with rarer mental illnesses such as schizophrenia or underserved populations. So I think it's beholden on us to really look across our samples, not just at the survey data and the quality of those, but also at the biological samples. So, you know, the UK Biobank is a very biased sample. It's used extensively, but it's an extremely biased sample. It's just not representative, and we need to do something about that. I think Ed's point earlier about how we come together now to improve the quality of the information available, both for great biology as well as epidemiology, informing the sampling, informing the stratification of the analyses in biological data sets, imaging data sets, for example. I think that's really, really important. So definitely agree that sampling is a big problem. You know, I mean, your results often just tell you who your sample is. That's my, it's just.
All right, thank you. And I'm going to bring another one of the themes that I mentioned, which is integration across, not just across science, but delivery to patients, which is the most important thing. How are you tackling that with regards to the science that you've been generating in Cambridge around inflammatory response and its effect on the brain and on affective disorders, specifically, it seemed to me?
Okay. Thanks, Shahzad. Thanks very much for the question. If I begin by saying I completely agree with what you said about the importance of integrating mind, body and brain. And I think one of the good things about COVID is it has brought people together collaboratively, and that has been, you know, fantastic to see. And Jerome talked about it, you know, our experience in the CNS COVID Consortium has been excellent across disciplines, neurology, psychiatry, etc. And I think that's really important to grow from. You also mentioned the stress of finding funding, and I have to reflect that, you know, actually the stress of finding funding does tend to push us apart a little bit in a slightly fragments the interdisciplinary coherence that I think we all want to achieve. So I think it's very important for us going forward to, you know, to really be as joined up as we can and resist that pressure. I mean, in terms of what we are actually doing to translate this into a different way of sort of practice, I mean, I think at the moment we're focused on biomarker discovery, target identification. Maybe, you know, that opens up opportunities to repurpose anti-inflammatory interventions, pharmacological, maybe other biomedical ways of tackling inflammation when we can be sure it's, you know, contributory to symptoms in particular individuals or groups of patients. And that would be the long-term thing.
And are you sourcing patients from outside Cambridge as well? I was pretty impressed by Jerome Breen and how they assembled, you know, what was not just a single centre study pretty quickly. Yeah, that is the that is the same consortium I'm talking about. Yeah, right. And I think that has come together really well. And I mean, obviously, you know, that's testament to Jerome and then Michael, who you know, co-leads it. But I mean, it's been remarkable to me to see spontaneous collaborations across disciplines, and I'm sure other people have had similar experiences. Just to finish on the sort of practical side of things, what I was saying about biomarker-driven drug discovery and so on. I mean, I think that does make sense, but it is obviously a slightly longer game. I think it's worth reflecting that they're probably, you know, there is information we can get about the immune system in lots of patients, you know, even at a fairly basic level. And I think, you know, increasing the scale of that, increasing awareness, perhaps, you know, finding ways to communicate with, you know, people who have experience of these post-COVID symptoms, what, you know,
the role of inflammation might be, and what are some simple and safe anti-inflammatory lifestyle changes that they might want to consider thinking about.
Thanks. Can I ask Kirsty and James, as sort of lived experience representatives, and any others there, have you, during this period, sensed there's been any integration in delivery of care with regards to mental health? Have there been any changes that you think are positive, or have gaps been amplified?
Do you want to go, James?
You go for it, Kirsty.
So I think there has been some integration. I think the positive from my experience is the accessibility of support has been improved through digital access, although I appreciate fully that doesn't work for everybody, and I think choice needs to be the key word moving forwards in how services are delivered. I think where the barrier is actually is in integration between physical and mental health services. And we've seen that very much from a long COVID perspective, that there tends to be an overemphasis on mental health when we don't understand what is going on with a condition, and that can be quite a barrier for people experiencing that condition.
Yeah, well, that's something for us to think about as we go forward. Funding integrated studies rather than single speciality studies, not just as an MQ, but for the sector as a whole. So if I could return to an original thought that I had. Oh, Dixon, over to you.
No, I hadn't said it. Did you? Sorry, I might have missed.
You put your hand up.
Oh, no, sorry. Yeah,
but Kathryn is definitely putting her hand up.
Yeah, so I just wanted to say about that. We're currently funded by NIHR, and we're hoping that this might be something that we can effect nationally, and it's slightly turning things on its head. So we're trying to get every single, the Clinical Research Network currently recruits about 600,000 patients a year. The vast majority of those, 90% of them, are in physical health trials. And we're trying to get routine collection, as if you were collecting basic demography of mental health data. So a core mental health data set in all physical health studies. So it's slightly flipping it on its head. I think we're slightly better actually in mental health about thinking about the physical health of our client group. I think it's really terrible the other way around. There's really no thought about the mental health of people in physical health services. So the multimorbidity agenda will help that too. And if we can get this core minimum mental health data set embedded as a routine, that would be fantastic for data sets. And HDR UK are also thinking about the same thing.
Thank you. Matthew, can I bring you in? I did warn him, so I hope a little bit earlier. So, given the varied elements that are both under your control and not under your control, if there was one thing or one study that you could design that brings together some of these strands that we've been discussing around COVID, what would it be?
Yeah, well, of course, that's an impossible question, but it's not a single study. I think if you look at COVID and look at what's impressive about what's happened, and actually, you could say all sorts of things about the UK's record in terms of responding to the pandemic, but I think one or two things that absolutely stand out in terms of really effective integration of clinical and academic systems when it comes to things like the recovery trial, when it comes to the development and testing and rollout of vaccines, when it comes to health data and being able to know what's going on across health systems. The UK has made a very substantial contribution to that. And I think when you look at the kind of questions we're grappling with for mental health, a lot of this is really, these sorts of studies, these sorts of achievements don't come out of the blue. They don't come because a bunch of people start doing something in February, March last year. They come because there's sustained infrastructure and a sustained commitment to making those sorts of things possible. And I think that's really where I'd say mental health needs to kind of get a grip and get a. I mean, you know, and I say mental health, I mean funding, and you know, serious kind of cross-funder activity to try and bring together the sorts of things we're talking about. Because you know, if you look at the population of people who've had mental health problems or high symptoms of mental disorder as a result of public health measures and lockdown and so on, the sorts of things which Kathryn was talking about, you know, our intelligence is fairly limited in terms of what the population's mental health is. And then if you think about the sorts of challenges about how you address that, you need to be able to establish trials at scale pretty quickly in terms of sort of digital interventions or other interventions which might be available to address this. And I think similarly, when you look at the people who've actually suffered COVID and are experiencing some of the challenges following that. So I really think it's about having integration of joining up the research community, but linking that to the health systems and beyond, and ensuring that there is a kind of route to the funders, and that's something which is valued. So of course I've answered it by saying we want everything.
Yeah. Okay, Emily, can I ask you the same question? Dixon, you're next. So
yeah, I'm picking up from where Matthew left off, and totally agree. It require, but what if we were to treat mental health like so-called physical health? What if there was real parity? What if mental health, there is no health without mental health? I think we'd be being a little bit more ambitious at this point, because it's not enough to just say how difficult the problem is, as Niall was saying. It's also a demand about trying to make a difference in our lifetimes through interventions. And so interventions could be at any levels, and we need to think about everything from Dixon's talk earlier, like interventions might be simple and purpose, but what can we learn that could bring something that it might be a behavioural mechanism to mental health, and in fact in any domain at all. So what kind of studies do I really want to see, Shahzad? I guess the ones that I'm doing might involve things that don't look like mental health treatments at all and are very short, and might involve computer gaming to get rid of intrusive memories and flashbacks. That's for key workers, and I'd love to talk more about that another time. But what they really involve is trying to find interventions in the next few years, not just keeping counting how bad it is, and to involve people with lived experience in saying what they want help with.
Yeah, great. Thank you. That's really helpful. Dixon, can I move over to you?
Sure. Just to carry on from where Emily left off, I totally agree with that. I think one of the challenges that we're facing, particularly in this part of the world, not only with regards to mental health, but with COVID as well, is access. You know, equity in vaccine distribution, and it's almost like the challenges that you see with COVID are no different from the challenges that people with mental disorders see in this part of the world. So I would really love to focus on that particular area. If there was one thing, you know, I would focus on is really would be how to improve access, you know, in an equitable way. And obviously that goes beyond science on its own. You know, you have policy issues that are involved there, you know, international, you know, quite a lot of things. It's quite broad, but I think it's very important, especially if you look at the appalling vaccine distribution in this part of the world, you know.
Yeah. And that's a real intervention that can be made now. And if you buy the brain injury element of COVID, which I certainly do personally, then that's a real preventative measure that's here now and makes a difference. Kathryn, I see you have your hand up. No, is that legacy? Niall, can I come back to you? If we think about the splash, that the original paper that Emily was one of the main co-authors on, what's your objective sense of the impacts of that more than a year on? How do we sustain this momentum that I referred to at the start? what role will the Lancet play in that, for instance?
Well, I think that that paper was very important because, of course, there are data which we need to collect for which we have a limited time. You know, that now is the opportunity to do these studies. We've got to collect these data while they're fresh, or they go forever. What I'd like to see is a longitudinal, to use that word again, process of reviewing priorities, of seeing which questions have been answered, which have fallen by the wayside. I think what I'd like to see is also maybe a bit more of a focus on the global picture for countries which are not high-income countries, for which we have a pitiful amount of data, it must be said. The other thing which I'm a little bit interested in is what we might call the dog that didn't bark issues, things we were talking about a year ago, but which have gone quite quiet since. So what happened to psychological research into promoting adherence to infection control measures and resilience within that? What happened to research into the effects of media consumption and how this might be modified, what a healthy media diet would look like? I've seen surprisingly little on this, so we need to decide if it's worth revisiting these questions while we still have time. Certainly I can say that the Lancet Psychiatry is committed to a process of sticking with this issue, to reviewing the questions which were asked by the original group, and to continuing 1 year, 2 year, 3 years into the future as the situation evolves.
Thanks very much. Kirsty, is there something from
Yeah, so some of the questions that are coming in are about sort of the design of clinical trials and how can we make them more responsive to the people that are being most affected by this. And I know James has some thoughts on that.
Yeah, I was really struggling to identify my one research study, and I think we could, like, we're all going to struggle to just pick the one, maybe a program of research. I would go with that. I'd be tempted to go with that question of what keeps people well. I think that's really important as well. And like Emily said, Emily, who needs no introduction, I thought that was quite funny, that we want to see a difference made in our lifetimes. We don't just want to be good at documenting decline. But I think the one thing that I would really pick out would be, you know, how does co-production of research work, and how can we do that a bit better? Because I think that the demands and the speed at which people had to work in their research in the pandemic meant that sometimes co-production was missed out at the level that it was needed and in a very meaningful kind of way. And I can understand that on the one hand, and we kind of think that we're quite good at it in mental health compared to physical health. But I'm sort of questioning, really, was that sustained infrastructure around that, you know, that Matthew was talking about, was that really in place so that those people could be called upon immediately, and not just the same old people, you know, not just wheeling out the same people with their lived experience who are really used to contributing, but those voices that perhaps we don't hear, and those voices that might be most affected in a pandemic. So I think we need an agile, really well-defined system for what does co-produced mental health research look like, what is the kind of impact we're going for, and I just think it can't be missed out. Even in a pandemic, it's never optional to consider the actual people that you're researching and trying to help, and that goes from design all the way through to dissemination, because, you know, who are we talking about? People with mental health problems or developing mental health problems or needing to keep good mental health living through a pandemic, and where does that start? In the lived experience of the pandemic. So I think that that would be my research program. I just need a massive grant to fund it.
Thanks very much, and very important to remind us of that focus. And Kirsty, anything else from the audience?
So a lot of the questions are, again, they're focusing on inequality, which I think we have addressed. I mean, Emily, as an occupational therapist, Emily's research speaks to me. Video games, things that we do every day that keep us well, is definitely somewhere I think we need to be looking at, including work. And that's one of the things that the long COVID support group are doing a lot around employment. And it was shown in some of the earlier presentations that unemployment is a risk factor for mental health. So we do need to make sure that the people keep their jobs.
Great. Well, thanks very much. I mean, I think what's been reinforced to me, and I hope everybody else, is that we have a responsibility now. This brief moment in the sun that we appear to be going through as a community that's interested in mental health in its broadest sense and the sciences that are associated with it. we have a responsibility not to waste this opportunity. We have a responsibility to integrate all of our activities. And that's a key purpose of this meeting, I might add. It is one of a kind in terms of the breadth and depth of abilities that it brings together, albeit virtually this year. So integration is key. Quality can never be compromised in the name of rapid, fake science or junk science or whatever you want to call it. And then thinking about delivery and everything that we do, delivery to the end needs of the patients that we're trying to make a difference to. And so any other comments from the panel before we close? Have I missed anything? Niall?
Yes, really just to reiterate James's point about co-production. I mean, as a research community, we understood that there were problems with ethics in research. We set up systems to deal with that. We understood there were issues with pre-registering outcomes in research. We set up systems to do that. I think it's time to do that for co-production.
Great. Thank you very much to all the panelists. Oh, we have some more comments. Or is it a bye-bye? All right. See you. I'm going to hang up now.
Thank you.